Hi, it's me, Dr. Mohammad Kadhafi. You are watching Dr. Mohammad Kadhafi Views. Let's start our new topic. And where there is a morning, there is a good morning. And where there is a evening, there is a good evening. I just want to start one very good topic, very important topic, with the analogy or the metaphor with the one case. The topic is a clamp paralysis. So now, a patient present 2 days post-trauma vehicle accident, and the patient is an 18-year-old male who is complaining of the severe right-sided neck pain, headache, vision issues, right hand issues, and the patient state he did not go to the emergency department or file an accident report. He reports he was just messing around on his dirt bike and he lost control at about 25 miles per hour and loaded on his arm with its positioned about his head. During this physical examination, there is a ptosis, meiosis, and the right eye in the right eye, and his fingers are fixed in a claw-like appearance. He was normal, and brachioradialis, brachialis, and the tricep reflex was there. He has decreased vibration and a soft touch sensation of the medial hand and the forearm. There is also a decreased finger abduction strength, and it is very painful for him to perform left lateral flexion. All other vital signs are within normal limits. So, what could be our primary diagnosis and appropriate next step? Actually, the clamp palsy with associated Horner syndrome refer out for the CT myelography and the surgical consult. Klumpke or clamp palsy is a brachial plexus lesion of C8 and T1 spinal cord and can sometimes also involve the cervical sympathetic ganglia. In these cases, the patient will present with the claw and a deformity and associated ptosis, meiosis, and hydrosis. Statistically, surgical correction in severe case of the brachial plexus injury shows the best prognosis. In severe brachial plexus injury, where there might be suspected avulsion like in the case presented, and the CT myelography would be the best imaging option. In severe brachial plexus injury where there might be suspected avulsion, like in case presentation such as the CT myelography would be the best imaging option, and the young male post motorcycle accident have the highest incidence of the brachial plexus injuries. Here I just want to put some more detail over the clamp paralysis, clamp palsy. As you know, this is a C8T1 and a spinal cord and a lesion, and sometime also it was the cervical sympathetic ganglia. In this case, patient present with the claw hand, and it's like a claw hand like this, and the deformity associated with the ptosis, meiosis, and hydrosis. But as I mentioned, I want to about this more detail. The Klumpke palsy, named after the Augusta Jeanne Klumpke, is a neuropathy involved the lower brachial plexus. In contrast, the most common, the Duchenne's palsy, involves the more cephalic portion of the brachial plexus, such as C5 and C6. The brachial plexus is a bundle of the individual nerve that exit between the anterior and middle scaleni muscle and in the anterior lateral and the basal portion of the neck. Although the most common anatomic presentation of the brachial plexus is between the anterior and middle scaleni, and there are variations, with the most common being penetration of the anterior scaleni. The main mechanism of injury to the lower brachial plexus is hyperabduction traction, such as people hyperabduction traction, and this hyperabduction traction, and depending on the intensity, it will lead to sign and symptom consistent with the neurological insult. The purpose of my lecture here is to explain the similarities and differences between Klumpke palsy and the Duchenne palsy, and I want to describe the primary mechanism of injury in Klumpke's palsy and describe the evaluation of the patient with suspected Klumpke's palsy, and I want to describe the evaluation and treatment of Klumpke palsy, and I want to address the interprofessional team approach in management and condition. As you know, the Klumpke palsy, named after the Augusta Jeanne Klumpke, is a neuropathy involving in the lower brachial plexus. In contrast, the more common ERB Duchenne palsy involves the more cephalic portion of the brachial plexus C5 to C6, and the brachial plexus is a bundle of individual nerves that exit between the anterior and middle scaleni muscle in the anterior, lateral, and basal portion of the neck. Although the most common anatomical presentation of the brachial plexus is between the anterior and the middle scaleni, and there are variations, with the most common being penetration of the anterior scaleni. The main mechanism of injury to the lower brachial plexus is hyperabduction traction, and depending on the intensity, and it will lead to sign and symptom consistent with the neurological insult. The most common etiology resulting in Klumpke palsy is a hyperabduction trauma to the arm that has enough intensity to traction the lower brachial plexus, and trauma during birth can cause brachial plexus injury. But again, hyperabduction and the traction force to the upper extremity are usually present. A comparison injury has similar sign and symptom. For example, apical lung tumor gets to the size where it possesses on the cervical sympathetic ganglia or C8 or T1 nerve root. If there is a sympathetic involvement, Horner syndrome may present. Approximately 50% of all brachial plexus injuries happen between the age of the 19 and 34. As you know, the pathophysiology of this condition is one of the neurological insult. For there to be sign and symptom, first there must be enough injury to the nerves. Sudden and Sunderland developed one way to understand this nerve compromise by examining the injury micro and macroscopically. And nerve comprise has three main categories, such as neuropraxia, axanotomesis, and neurotomesis. Actually, during the neuropraxia state, there is no macroscopic damage, but there is a functional damage, and most are self-resolving with physiotherapy. The other two categories, such as the axantomesis and neurotomesis, are more serious cases, as there are macroscopic damage, with neurotomesis having the less ideal prognosis, usually resulting in an non-functional neuroma. The most common finding at all ages or all stages of the neurological degeneration should be dermatome and myotome abnormality specific to the nerve root. The history presentation by the patient usually despite a long axis hyperabduction traction injury with high amplitude and velocity. The typical patient presentation is a decrease of sensation along the medial aspect of the distal upper extremity along the C8 and T1 dermatome. The patient might also present myotome finding that can range from the decreasing muscular strength to muscular atrophy and positional deformity. For example, if the neurological damage has led to muscular atrophy and the tightening, the patient may present with a claw hand and the deformity present as a finger and the wrist flexion. The patient may also describe the severe pain that starts at the neck and travels down the medial portion of the arm. One other sign of the lower brachial plexus injury is Horner syndrome. Because of its approximation to the T1 nerve root, it may damage the cephalic sympathetic chain. If this happens, the patient will develop ipsilateral ptosis and hydrosis and meiosis. I want to repeat because the same condition happened with my case here, which I showed you the 18-year-old male I presented to you. It was with the lower brachial plexus injury, for example, the Klumpke's palsy associated with the Horner syndrome, and as you know, because of the approximation of the T1 nerve root, it may damage the cephalic sympathetic chain, and once the cephalic sympathetic chain has been injured, the patient will develop ipsilateral ptosis and hydrosis and meiosis. For evaluation of this injury would start with through patient's history, physical examination. During the physical examination, the practitioner would assess the evolved upper extremity. If neurological findings are present, diagnostic imaging would follow. Cervical and thoracic radiograph should be seen along with the computerized tomography or magnetic resonance MR are all valuable tools. So the conventional radiograph will at most rule out a neurological compromise secondary to heart tissue. For example, fracture impeding the nerve root. With neurotomy, with non-traumatic case, conventional radiograph may also rule out any space-occupying lesion in the superior mediastinum and basal portion of the neck. CT and MR evaluation are more precise when considering a neurological insult. CT myelography is a more specific and sensitive evaluation. MRI contributes less radiation, but it also has a less sensitivity and specificity compared to the CT myelography. Other tests could include in a histamine injection and nerve conduction velocity. They use the histamine test to approximate the neurological injury maximal or distal and dorsal root ganglion. If the injection of histamine causes an intense dermatomal flare reaction, the insult is proximal to the dorsal root ganglion, and the nerve conduction velocity test definitely measures how fast neurological impulse travel and can locate the injury. Treatment: because of its location, Klumpke's palsy can also affect the axillary artery, and this can be from both the hyperabduction stretching injury but also a crush injury to the local area. If there is a severe vascular compromise and the patient will undergo emergency surgery, fracture correlate with his condition and treatment typically involves surgery. With injuries that are closed, meaning they do not have any obvious break through the skin or a vascular compromise, there is a conservative option. Spontaneous recovery from nerve palsy is possible, but it is important to note that the most C8 and T1 nerve palsy do not recover without intervention. because the conservative treatment include exercising supportive muscles and stretching affected muscles helps to maintain the range of motion and aid in full recovery. The nerve will heal, but most are in mild cases. In 3 to 6 months, if there is no improvement, surgery will take place. Surgical correlation mostly involving nerve graft, but in injuries proximal to the dorsal root ganglion, neurotization is the recommended procedure. As you know, the differential diagnosis here, the similar sign of the Klumpke's palsy is palsy. This injury affects the upper brachial plexus injury, which also usually results in the dermatome and myotome finding along the C5 and C6 pathway. C6 path, for example, someone with palsy usually have the waiter's tip presentation and fixed pronation of the forearm with an outward facing palm. And other similar condition is the distal nerve entrapment of the ulnar nerve at either the medial condyle of the Guyon's canal, and it referred to the ulnar nerve entrapment and can produce similar neurological finding as the more proximal, such as the Klumpke's palsy. One big difference is there will be no involvement of innervation proximal to the lesion. For example, you will not see the pectoralis major involvement with the ulnar nerve entrapment. Thoracic outlet syndrome can also show similar symptoms, and typically thoracic outlet syndrome is a compression injury to the brachial plexus from the rudimentary rib, or we can say the first rib or the clavicle on the ipsilateral side, and this could be the post-traumatic postural driven and or genetic. In contrast to the Klumpke, and I must say there is a thoracic outlet syndrome will affect more than just a C8T1 nerve root, but the Klumpke, but like Klumpke, it is also an affect the axillo-subclavian artery, and below there is a list of the most common differential diagnosis for the Klumpke's palsy, such as distal ulnar nerve entrapment, thoracic outlet syndrome, apical lung tumor, neurofibroma, disc herniation, shoulder impingement, clavicular or vertebral fracture. In 2006, the study found a better prognosis in children with brachial plexus lesion compared to the adult undergoing microsurgery. An explanation for this might have to do with shorter distance and higher threshold for the regeneration and increased cognitive adaptability. But another article showed similar finding that the microsurgery helped restore hand functions in 75% of the cases in 8 years. So the spontaneous recovery is possible with less intense injury. And the Zuckerman and colleagues found that there is a similar group, are one undergoing surgery and another past the point of surgery, and a similar functional outcome in 2 years. Most profession will agree to a better prognosis for more severe injury with a shorter time to onset of surgery. Post-operative and rehabilitation care is very, very important with brachial plexus birth palsy. If there is no fracture or dislocation present, exercise focusing on stretching and strengthening the restricted muscle will help in functional recovery, and the goal of the rehabilitation include increasing range of the motion, preventing muscular atrophy, and pain control. Stretching of the tissue will aid in the prevention of the muscular atrophy. The repetitive stretch has shown positive result with limiting atrophy in others. So the electric stimulation may also provide some therapeutic benefit, and the electric stimulation has positive result with the denervated soleus muscle, but still there is some limitation. So the brachial plexus injury are often difficult to manage as a portion of them recover spontaneously. It is important to develop strict guidelines that will get the patient to surgery faster, and the professional who is monitoring the patient must track the progression and regression of neurological symptoms. In more severe cases, if the time to surgical correction is less than 6 months, there is a greater prognosis for the muscular recovery, and exactly 90% of the patient had grade 3 muscular recovery when they underwent surgery at 3 months, and at 12 months the number was only 35. So you can understand, if you are delaying the surgery, you are not helping the patient, actually you are partly harming the patient. So it is a little bit strong word, but I hope you will like my presentation. I will present with you one more presentation. I request you please share, like and subscribe.